So good afternoon, everyone, and welcome to today's webinar on demystifying buprenorphine treatment in the outpatient clinic setting. I'm Jody Mitchell, Senior Director of Government Relations and Policy at the Center for Health Affairs, and I oversee the center's Opioid Data to Action grant, and we're very grateful for CDC's funding of this important work in Cuyahoga County. We are excited to host this important discussion today. As the landscape of addiction treatment continues to evolve, the role of buprenorphine in managing opioid use disorder has gained significant recognition. Yet despite its proven effectiveness, barriers, whether clinical, regulatory, or societal, still prevent widespread adoption in outpatient settings. Today, we're trying to break down those barriers, clarify some misconceptions, and provide practical guidance for integrating buprenorphine into everyday clinical practice. We're thrilled to have a panel of experts who bring deep knowledge and hands-on experience working with individuals with substance use disorders and addiction. They help us navigate the nuances of buprenorphine treatment, address common challenges, and answer your questions along the way. So we really want this to be an interactive session. Please use the chat function to put your questions in. If you are unable to chat, you are able to come off mute. However, we do ask that you stay on mute so that we don't get the background noise throughout the session today. We will, as I mentioned earlier, be recording this, and we'll release the recording, post that to our YouTube channel so you can access that or circulate it to colleagues after our event today. Let's dive in. It's my pleasure to turn it over to Dr. David Magolius, Director of Cleveland Public Health Department, who will set the stage for the conversation today.
All right. Well, thank you all so much for being here. It's great to see so many folks on the call. So in my role as the Director of Public Health, trying to improve quality of life and life expectancy in the city of Cleveland. Did you know, and I think judging by the names on this call, many of you did know this, that sadly we lost about 300 people just in the city of Cleveland to drug overdose deaths in 1 year, a couple years ago. 300 deaths. As a comparison, we lost about 150 people to homicides. So if you just read the news or listen to the news, you might think that there are maybe 10 to 100 times more homicides in Cleveland than there are drug overdose deaths, but it's about twice as high for drug overdose deaths. The good news is that it's preventable. We can help people, we can treat people, and many of you in the audience know this already, but there's this magical medication that by itself works to save lives, and it is called buprenorphine, or brand name Suboxone. And so many parts of the country already know this. Parts of Cleveland know this, but it's really important for all of us to know this, because even me, Dave Margolius, when I first got my license to prescribe Suboxone back then, you needed a special license. I sat on it for about 2 years because I was too scared. I didn't know what would happen if I started prescribing. But then fortunately, someone called off and I had to write 8 prescriptions in a day. And I was like, wow, this is much easier than warfarin and insulin. So I hope you can all have that experience as well. And I'm going to turn it over to 2 incredible physician leaders who know this work, who have been doing this work at the centers, Dr. Dodi Rimalan, Chief of Primary Care with the centers, and Dr. Ellie Yanchar, Chief of Psychiatry with the centers. Thank you.
Thank you, Dave. We're so excited to have you on this call. So I'm going to kick it off. I'm Ellie Yanchar. I'm the Chief of Psychiatry at the centers. I'm a family medicine physician and also a psychiatrist. And we're really excited to give this talk today on demystifying buprenorphine. And I think most people on this call are some level of a clinician. I may interchangeably say buprenorphine and Suboxone without thinking about it. It's the same essential medication. So I just want to outline that. And we really, really hope this can be an interactive conversation. If you put something in the chat, Jody will probably flag us, but we don't mind being interrupted along the way to have a conversation. So with that, we will go to our next slide. So I think Dr. Margolius sort of hit on this. Why are we talking about this? Why is it important to increase access to this life-saving medication? Because we know Ohio has been hit very hard by the opioid epidemic. I believe at one point we were one of the top 2 states for overdoses, and we're slowly creeping down from the highest, but we're still up there in the top 10, and certainly this was from the Big Gun Center in 2025, just kind of highlighting that we still have many, many cities that are in the top 60 for opioid death rates in Ohio. Just a couple years ago, we were triple the national average. And so we want to help decrease those numbers slowly but surely. Oops. Jody, I'm gonna get my hands off these slides. Go for it. Next slide. So we know that opioid use disorder is it's an illness. It's a chronic illness and it's a treatable illness. Just like, I think I like to say this, right? It's not a moral failing. It's an illness that can have periods of remission, periods of exacerbation, just like COPD, hypertension, depression, other things. What's wonderful about it is that we have a medication, buprenorphine, and also methadone, but we're talking about buprenorphine here because we are not a methadone clinic. Dr. Imlin and I can reduce mortality by 50%. There are very few things that can reduce mortality by 50%, but this is one of those medications. And one of the most impactful things that we can do to save lives is to just increase access in really easy ways. I should mention, so we at the centers operate a walk-in MAT clinic, which is medication-assisted treatment for opioid use disorder, where we prescribe Suboxone 5 days a week. And so when we have folks come in, they fill out a pretty quick triage form about what they're hoping to accomplish that day. So you may see some of those notes throughout this presentation, but this was one from one of our patients who came in and said, my habit is out of control, afraid I might die, hope to get on Suboxone soon, maybe one day. I think, Dr. Rimlin, this was the haiku, pretty close to a perfect haiku that we got from this patient. Okay, so historically, there have been a lot of perceived barriers to buprenorphine prescribing. I think I started prescribing it back in about 2017 when I was training in California. And there were a lot of perceived barriers in both psychiatry and primary care. This article was from 2018, and I'm not going to read all of it, but I'm going to highlight some of these points because I think they're really important. So there are a lot of still myths, but buprenorphine treatment is more dangerous than other chronic disease management. As Dr. Margolius said, it's actually much simpler than a lot of things we do in medicine or psychiatry. I would rather prescribe buprenorphine than a complicated insulin regimen or warfarin or clozapine. That it's much simpler in a lot of ways. And so that I think is something that continues to need to be debunked. There's another huge myth that use of buprenorphine is just simply replacing one addiction for another. I think that still persists today, and that is just not correct. Addiction, right, is defined by compulsively using a substance despite harm. This is taking a prescribed medication for a chronic illness, and it is not an addiction, or you cannot get high off of Suboxone. There's the myth that just detoxification from opioids is effective, right? That means going to the treatment center, getting off the meds, feeling like crap for a few days, and then just being sober. There's really no data showing that that's an effective treatment for opioid use disorder. People are much more likely to relapse or die. And in fact, lots of people might actually have a higher likelihood of overdose because you have eliminated your tolerance to the drug. And then if you use it again, that's when you're more likely to die. Prescribing Suboxone is time consuming and burdensome. As we mentioned, it's really not. It's really, once someone is on an induction, which Dr. Rimlin's going to talk about, it's actually one of the most simple, joyful kind of visits you can have in clinic in a busy day. And then, the myth that just reducing prescribing of opioids in the healthcare setting will reduce overdose deaths. That really hasn't shown to be true. It's still happening as it should be, right? We shouldn't be prescribing long-term chronic opioids for people, and we know parts of what led to the opioid epidemic, but really people just shift to the illicit drug market. I think every time I do an intake with someone, the most common thing I hear is they were prescribed an opiate and then they were slowly cut off and then they had to figure out other ways to manage their pain or their addiction. Okay, I'm going to move to the next slide. So as I was alluding to, the realities of office-based buprenorphine. So again, we're doing this prescribing in an outpatient clinic. We work in a federally qualified health center. We do this in our outpatient clinic. It's so rewarding. It's really, really wonderful to work with patients and be able to be a partner with them and allow them to rebuild their lives. I saw a patient yesterday and I kind of said, man, we've been together for almost 3 years now. You've been sober for 2. He's got his license back, paid, took care of his warrants, some of his legal things that he had to. He's back with his family, and that's just so rewarding to be on that journey with folks. And because you have more frequent visits, especially early on in treatment, that you really get to develop these really close relationships with patients and really know them and feel like they're part of your medical family there. And it's very rewarding. You have deep gratitude from patients, which isn't why I think any of us go into medicine or any of these specialties, but it is really, really nice to be able to have that with patients. And then you can work on improving other aspects of folks' health. So kind of most people, when they're in a cycle of addiction and their most pressing need is to, get the drugs, right, to make them not feel bad or in withdrawal. They're not probably taking care of their hypertension or their hepatitis C or their other mental health needs. And so once you're able to help someone get on Suboxone, then you can really be a partner with them and help them tackle some of the other things, which is also really rewarding. Dr. Rimlin and I have the benefit of being able to do all of that in our clinic, and we treat a lot of patients for their hepatitis C in our clinic, depression, lots of different things. And so this is kind of the first step in a safe place to allow people to get connected to healthcare. Okay, Dr. Rimlin is going to talk a little bit about how this medication works.
Awesome. Thank you so much, Dr. Yancher and Dr. Margolius. Okay, so I want to just start with like a very brief review of how buprenorphine actually works as a medication, and then we'll dive into how we actually get people on this treatment and help them stay on this treatment. So buprenorphine has kind of 2 properties that make it just a really amazing life-saving medication. So the first is it is what's called a partial agonist. So the buprenorphine molecule binds to our mu opioid receptors in the body and turns them on a little bit, right? Turns them on 40 to 50%. Fentanyl, heroin, opioid pills, and methadone treatment are full agonists. So they're binding to the mu opioid receptor and turning it on to 100%. And then there are other medications that are antagonists, like naltrexone, brand name Vivitrol, right, which binds to the mu opioid receptor and just kind of puts an X on it and prevents anything else from binding to it, but doesn't actually activate it or turn it on. And then the second concept is this medication's affinity for the receptor. So buprenorphine has a very strong affinity for the mu opioid receptor, which means that we say to patients, like, it's very sticky, right? It latches on and it doesn't let go, and it's sort of stickier than fentanyl or other opioid substances that they might be using. And so another property of it is what's called the ceiling effect. So this green line or teal line in the middle here is buprenorphine. And so as we increase the dose of buprenorphine that somebody is receiving, at some point it plateaus, right? And even if the dose is escalated, there's a limit to the effect of the medication, especially with regard to respiratory depression. So this makes it a really, really safe medication, right? Somebody with opioid tolerance really cannot overdose on buprenorphine, right? Even if they took higher doses, like they would kind of hit the ceiling and they wouldn't overdose on it. And it also limits the euphoric effects, right? So people aren't, experiencing a high or euphoria on buprenorphine. So I think, these combined properties make it, overall a really safe outpatient medication, and also one that's really effective, as we'll talk about. Okay. So we wanted to talk now about kind of some of the details around what does it look like to get somebody on buprenorphine in your outpatient clinic, right? And so that's what we refer to as a buprenorphine induction. Inductions are done in lots of settings, right? Some folks are doing these in residential treatment facilities. Folks are doing them in the hospital. But we know the reality is that many people prefer to do this at their own house, right? And don't want to go into a residential treatment center, and they want to get on this medication on their own, with the support of somebody at home. And so that's the kind of work that we're doing. So the vast majority of inductions that we're doing in our clinic are what are called out of office or home inductions, right? Where we are talking to the patient, we are giving them, prescribing them buprenorphine as well as some other medications to help their withdrawal. And we are giving them instructions on how to start this medicine safely and effectively at home. I'll say, like in our clinic, we certainly offer people the opportunity to start it in clinic with us, right? To have their first dose in the office with the doctor and nurse. But the reality is most people don't want to do that, right? And it's tricky, and timing your withdrawal and being really crummy and sick when you go to the doctor's office is just like what it doesn't work for a lot of people. And what we find is the vast majority of folks prefer to do this out of office. Okay, so what's the best way to get on buprenorphine in 2025? I would say the best way to get on buprenorphine is any way this person can get on buprenorphine, right? There's not a best way. Like, we want to work with somebody to effectively get on this life-saving medication, and there's not necessarily one method that works for everyone or that's preferred over other methods. So we wanted to really go over kind of what it looks like in our outpatient clinic and how we're thinking about the best induction method for individual patients. So this is a table from an article that came out in 2023 by Melissa Weimer and a group. It was published by ASAM, and so it is an update. This is actually an excellent article for anybody doing addiction medicine. So Melissa Weimer and group really go through in this article what are some kind of updates in the way we think about starting and prescribing buprenorphine in the fentanyl era, right? Which they're referring to as high potency synthetic opioids, which really just means fentanyl, because it is a bit different than it was when the supply was heroin or oxycodone. So they outline in here 3 different methods that we're gonna go through. The first they refer to as a high dose buprenorphine induction. The second they refer to as standard, and we're gonna kind of lump those together because they're actually very, very similar. And then they also talk about a low dose bup induction, which some people refer to as a microdosing induction. So we're going to start by talking about the standard and high dose induction, which really are pretty much the same. The thing that differs is really the starting dose that you are recommending somebody take, which we'll talk about. So for these kind of more standard or high dose inductions, this, in order to talk somebody through this, and I would say, I guess stepping back, this is probably 90 to 95% of what we're doing. Our clinic is doing some low dose inductions, which we'll talk about, but they do have some important limitations. So I'd say like most of the time, this is the method that we're using with patients, and most of the time it works, and and folks are successful. In order to do this, somebody does need to abstain from opioids and be in at least moderate opioid withdrawal. The amount of time that we tell folks to abstain from opioids is kind of variable, but for folks using fentanyl, at least 24 hours, ideally 36, maybe 48. Right, a little bit more time than was required with heroin, just because fentanyl sticks around in the tissues for a long time, right? It's lipophilic, it hangs around in the fat tissues. And so unfortunately, folks do have to wait a bit longer. Once somebody is having some withdrawal symptoms, we prescribe them a number of withdrawal support medications to treat the symptoms of withdrawal. These are things like clonidine, like Zofran to treat nausea, Imodium, a muscle relaxant. So we prescribe them those medications and instruct them to take those first and see if they can wait a little bit longer. And then essentially I tell people that once you feel like, you can't tolerate your withdrawal anymore, it's time to take your buprenorphine. And then really the difference between the traditional and high dose is just the dose that we're instructing them to start with. And that I'd say is kind of determined by their usage patterns. This is just a really great schematic from the Curbsiders Addiction Medicine series, which is also excellent for anybody who wants to learn. And this is from episode 7, where they talk about outpatient buprenorphine inductions. And so what they're talking about here is we just went through is if we go down the kind of fentanyl use pattern, which is most of what we're seeing now. They're telling folks, wait your 36 to 48 hours, and then advising to start with a dose of buprenorphine around 8 milligrams and continue to repeat until they feel better. And I would say that this is mostly what we're doing. The traditional induction dosing was more like 2 to 4 milligrams, but what we know with fentanyl is that folks need a lot more buprenorphine to feel better, and they need it faster. And so we are often advising folks to start with 1 to 2 films, so 8 to 16 milligrams on their first dose, and then they can take additional doses in an hour if they're still not feeling incredibly well. And so this is just, we have a number of kind of patient materials that we give to folks. So this is one that goes through all of those opioid withdrawal support meds. So I mean, this is pretty standard, right, in terms of what folks around the country are prescribing to help with withdrawal symptoms. But we check this off with patients and sort of go through what kinds of symptoms they experience and what support medications they want. And then this is like a little bit dated already, and we actually just asked our marketing team to update it because, but we have this protocol we can go through with folks, but we asked them to actually update it and have these doses changed to just lines to give flexibility for the docs to just write in a range or write in a suggested first dose for folks. But yeah, so these are just some of the things that we're using to talk our patients through this. And, I think the kind of transition that has happened in going from these sort of lower dose starts, right, 2 milligrams, 4 milligrams to more like 8 to 16 with fentanyl. In part, I actually love this graph that was presented at ASAM last year by the EM Ottawa group, and kind of highlights, I think, why these higher doses are just more effective for folks. So some people will refer to this 2 to 8 milligram window as like the precip window. And I think what's happening, right, remember, because buprenorphine has such a high affinity for the receptor, if there's any fentanyl still in the system, which there often is, it's knocking it off and binding to those receptors. And so folks are going from like 100% to 40% in minutes, right? So that is what folks refer to as precipitated withdrawal, or sometimes I think we experience just under treatment, right? They're not necessarily having precipitated withdrawal, but like 2 milligrams is just not enough to get somebody feeling better, right? So they are like, I took my bup and I still feel really crummy. Whereas once you get to kind of 8 milligrams, 16 milligrams, even if you're displacing some of the fentanyl, you're also turning on those receptors, which is what's needed to help somebody start to feel better and no longer feel the withdrawal symptoms. So I think inductions can feel intimidating to folks. I think when you're first starting, but I think what I would share is they're less intimidating than I think they need to be. And most individuals, I'd say like almost everyone we've encountered has had experience with buprenorphine, right? Like it's pretty rare that we're walking through this process with somebody who's never taken bup before. I'd say maybe a handful of cases, it happens, but like a handful in hundreds of cases. And so I think sometimes some of the most useful questions in my history with people are, what has your past experience been? What worked for you last time you got on? Right? Okay, great. You were successful. Like, how long did you wait? What dose did you take? And trying to replicate success that they had, or if something didn't go well, kind of troubleshooting with them. Okay, what might we be able to change next time to increase the chance that this is successful? And then, also precipitated withdrawal is still relatively uncommon. And it is really miserable for people, but it is not dangerous. And I tell my patients that, and I tell our providers that, right? It's not like alcohol withdrawal, which can be life-threatening, right? It's not like benzo withdrawal. Like it is, people feel absolutely crummy, but it's not dangerous. And really the first line treatment for precipitated withdrawal is actually additional buprenorphine, right? It's just getting more medicine on those receptors and turning them on to help somebody feel better. Great. I'm gonna touch briefly on low dose inductions. And again, if anybody has any questions or comments, please just stop me or chime in. Okay. So the third option listed in that article and that we do in practice is what's called a low dose buprenorphine induction, and many folks call it a microdosing induction. This is a really different way of getting on bup, and is really interesting. And what we do with a low dose induction, what it really means is taking, starting with very, very tiny doses of buprenorphine, right, like 0.5 milligrams. So these teensy doses, and gradually increasing the amount of bup each day while the individual is still using full opioid agonists. And then once somebody gets to a high therapeutic dose of bup, the full agonists are stopped. So in the outpatient setting, right, these are done in inpatient settings, and it's much different. But in the outpatient setting, what this looks like is you are telling somebody to keep using as you normally would. Just do what you normally do every day. And each day you're gonna take a slightly higher dose of buprenorphine. And essentially what's happening is the first day, a tiny bit of buprenorphine, might grab one receptor, right? This is kind of how I explain it to folks. Not enough to throw you into precip, but it's just grabbing one receptor. And then the next day it's gonna grab another one. And then the next day it's gonna grab two more. And so the buprenorphine very slowly starts taking over the mu opioid receptors. Over a period of, in the outpatient setting, this might be 6 to 10 days. In inpatient settings, often they're doing this more rapidly over 3 days or so. And so the benefits of this are really that it does allow somebody to get on buprenorphine without having to experience a full opioid withdrawal and without the risk of precipitated withdrawal. Folks might not experience withdrawal at all during this, or they may experience a kind of low level of withdrawal. And I mean, I had somebody do this with me last year, and she went to work every day and like didn't take off any time and completed this. And I had somebody do it recently too, who really was going to be with her kids that weekend and felt like she had to watch them and couldn't be sick, and did this successfully with like celebrating her child's birthday party. Now, there's definitely some downsides to this. Let me, which aren't on here, but we'll talk about. I think this takes a lot of coordination in the outpatient setting in reality, right? Which this kind of highlights. You're talking about often a 7 to 10 day protocol, needing to check in really frequently with people, I think is beneficial, and just a lot of troubleshooting. And I think so it requires a lot of coordination, and does require like just a high level of, I think, engagement by the patient. And so that can be challenging. And I think that's definitely a limiting factor of doing these outpatient. There was a study that came out just this year by Leslie Swen and a group in San Francisco that looked at low dose inductions into clinics in San Francisco that served a patient population pretty similar to ours. Right, a lot of folks were homeless, and they were doing these all outpatient, and they found pretty low rates of success and retention in treatment with this approach, which I would say is consistent with what we've seen. So I would say our practice is we're usually not offering this as first line, and but I think we have it. I think of it as like this is a tool in our toolbox for folks who we think would be more successful using this approach. And then, I also think there's a lot on the internet about this. There's a lot on Reddit about this. So like a lot of patients are trying this on their own, right? And so we meet folks who are like trying to go through a Reddit protocol that they found, and they've decided that this is the method for them. And so I usually tell folks who I meet in that case, well, like if you're doing this, I'd rather you do it with me if you agree to, and we can give you our protocol and like really check in and help you troubleshoot in ways that are evidence-based, and you have some support. So this is just an example of the protocol that we use, and we'll give all these slides for reference. But it's this is a pretty long protocol, so it's 9 days, which is on the longer side, and again with really frequent check-ins. All right. So after somebody is on buprenorphine, then we're talking about just continuing to treat them and buprenorphine maintenance, which is really easy overall, as Ellie was saying. And, so like the vast majority of patients we see in our clinic every day are in the maintenance phase, right? They're already on buprenorphine, and we're checking in with them to, make sure they're on a dose that's appropriate for them, and just checking in on sort of all other aspects of their health and treatment. So in terms of what dose range is sort of typical and I think evidence-based these days, really the dose of buprenorphine is really titrated to control cravings and withdraw symptoms, right? We want somebody to be on a dose where they're not having cravings, desire to use. If their goal is to stop using, they're able to successfully do that. And so, for folks with chronic fentanyl exposure, doses between 16 and 32 milligrams are pretty typical. And we do know that higher serum concentrations of buprenorphine do have overdose protective properties, because again, I think of it as all those receptors, if all those receptors are occupied by bup, the fentanyl can't get on them if you're to use, right? So somebody who is on a higher dose of buprenorphine is less likely to have a fatal overdose than had they not been on it. There's been a lot of recent change, I think, in how we think about the dose of buprenorphine in the state of Ohio and as a country. So the FDA actually just changed their buprenorphine label in December, just a few months ago. And to state that higher doses might be beneficial. Their past label had been interpreted by many people as having dose limits, and suggesting that doses, 24 milligrams and higher had no clinical effect. And so due to kind of a lot of more recent evidence and advocacy, that was actually changed recently. And yeah, so I would say the most In our clinic, we have folks on a wide range of doses. We definitely do have some folks who are on lower doses, who are on 8 milligrams a day, who've been on this forever, or whose goal is to be on a lower dose. I would say probably our most common dose for people who are using fentanyl is probably 24 milligrams. And until very, very recently, that was the maximum dose folks were allowed to prescribe in Ohio. And that changed a couple months ago, as we'll talk about. And then in terms of what maintenance therapy looks like and how frequently we see people, I'd say our practice is we're often seeing people every 2 weeks at the beginning. We're seeing them once a week. Sort of initially, if they're doing an induction, we want to check in with them frequently. We're often even calling them a couple of days later or having our nurse call them. But after somebody's on buprenorphine, we're often seeing them every couple of weeks. And then, at some point transition to monthly visits. And then I would say, once somebody is really stable and, their disease is in remission, we might be seeing them every 3 months for chronic disease management, just like we would see somebody with diabetes or depression every 3 months. And in terms of how long we keep folks on this, a long time, right? We know this is a chronic disease, and just like, I tell my patients, just like many people might need diabetes medicines for life to stay healthy, or folks might need an inhaler for life to stay healthy and well, like there are people who need buprenorphine forever to stay healthy and well. So, as long as people think it's beneficial, and for many people, that might be many years or even a lifetime. Okay. Awesome. I'm going to pass back over to Dr. Yanchar to talk about, so I guess all of this, right, was talking about the sublingual form of buprenorphine, so Suboxone, brand name Suboxone. There are also now multiple forms of long-acting injectable buprenorphine, which is a really fantastic treatment option that we also use frequently, and Dr. Yanchar is going to talk about that.
Okay, thanks, Dr. Rimlin. Okay, so we do have a couple of forms of long-acting injectables that we use pretty frequently in our clinic. So, and of course, the benefit to long-acting injectables, I'm a psychiatrist and a family med doc, but in psychiatry we use them a lot, right? Because someone doesn't have to take a daily medication, and that's really, really helpful for a lot of people. I know I struggle to take a multivitamin every day, right? But to take a film under your tongue, let it dissolve for 15 minutes, 3 times a day, can be difficult for some people. There's a lot of other reasons too. Someone might be on an injection. Some folks want to be on an injection because they think it's more protective for them from relapse, right? It takes away the opportunity to stop taking the film. Some of that, like those quick urges and craves, people when they use on an injection or Suboxone, they often don't get high, right? And it can be protective, and so it's protective in a lot of ways for that. And then there are some in Northeast Ohio in particular, there are some treatment facilities, long-term residential facilities, sober living facilities, different types of facilities that don't allow patients to be on films or the tablets of Suboxone, which is not necessarily the topic for this conversation, but it is definitely something that I think we're trying to work to decrease that stigma. But because of that, they will accept people on injections, but not on the medication. And so we see some folks come to us and say, I can only be here because if I take the injection, I can't take the film. And so those are just some of the reasons. And so we have kind of 2 available products for long-acting injectable buprenorphine. So the one that's been around longest is the Sublocade. We've been using that for quite some time. It's a monthly injection, and there's 2 available doses of it. So, historically, someone had to be on the Suboxone and tolerating it well for 7 days before they could start a Sublocade injection. The packaging, the label just is changing for that one, so it can be given after just 1 dose, which is much more helpful for folks. Some folks, they go through all the work to get on the Suboxone, and then it would just be much more beneficial if they didn't have to wait 7 more days to take the injection. It can lead to higher rates of success. So with the Sublocade, you have a loading dose. So typically you do 300 milligrams the first month, 300 milligrams the second month to reach a steady state, and then you go to 100 milligrams. What does happen for some people on Sublocade is as you're getting to that steady state, some folks do need supplemental film. So low doses of Suboxone for those first month or 2. We're talking maybe 2 or 4 instead of the 24 they were taking until they get the steady state. And then it sort of just naturally tapers off. I think that especially with fentanyl, we find that a lot of people need those supplemental dosing in those first couple months, and it's totally okay. It's totally reasonable to do that. And then the second medication is Brixadi, which we were so lucky to finally get in our clinic a couple months ago. And that has weekly and monthly options, which is really nice for some patients. Some people want to come in weekly. There's a lot of different reasons why someone might want to do that. And it has a range of dosing, which is nice compared to the Sublocade, which just kind of has the two doses. Again, I think I covered some of these. So the pros, there's a lot of flexibility with this. Once you're at that steady state, then it is quite forgiving if you're a couple days late, a week late, if you come in a little early. And that's really nice. So you avoid those peaks and troughs. And it can be lost or stolen. And so that's also really helpful. I don't think we put this in this presentation, but we have our treatment guidelines that we go through with patients when they come in. And one of them is it is exceedingly difficult to get early refills if medications are lost or stolen of this controlled substance. So hold on to it, with your life. And that does happen for various reasons. Our patients are in all sorts of circumstances, and it really sucks if someone loses their medication. It's really tough to get it an early fill or an override, and it usually requires a police report. And so this is better for folks who have trouble holding on to their meds. The cons, so there, is pain with injection. The Sublocade is a belly injection with a pretty big needle, and that is one thing that a lot of patients don't love. It's a smaller needle with the Brixadi, and it can be given in a couple of places. But it is an injection, and a lot of people have struggle with that. And it can leave a good lump too for some people. But really, this is a shared decision making based on patient preference, right? I had a patient that I saw yesterday who's been on Suboxone films for about 2 years, and he is now thinking, I think I'd like to go to the injection. I'm working all these other things, and he just feels like it's the right time for him. So there's really no time frame, and it can be really useful for people depending on
we have a question.
Oh yeah.
And I don't know at what point she was referring to this. I thought that the state of Ohio required 4-week visits regardless of how long the patient has been in recovery. Is this a change in past requirements?
Yeah, we're going to talk a little bit about that in a couple of slides.
Okay.
But there have been some great changes in the state of Ohio recently for frequency of visits. And we didn't put this in this presentation, but well, I'll get into that when we get there. I don't want to jump ahead, but yeah, absolutely. Okay. So in terms of urine toxicology monitoring, so similarly in our treatment guidelines, I always tell patients we do urine toxicology screens. A lot, this is really to get information because the state of Ohio also would like us to do this, but we would never, discharge you from our practice based on something that shows up in a drug screen. It's a point of conversation. If you are worried about something showing up on your screen, come in anyways. Please don't, because I think people are using other substances and they're worried about being discharged because they're using cocaine or marijuana or things. So we really use it as a conversation piece. And the other thing that I think is really important is the drug supply in Ohio and Northeast Ohio is so mixed now. And it gives us a lot of really good information on what might be mixed with people's substances, right? There's, meth and cocaine and fentanyl are very intermixed right now in a lot of different ways. And this gives patient information too. So let me go. So I think the most important thing is choosing the right test. We do a pretty sophisticated send out test. I can't think of the number, but we send it out and it gives us lots of confirmatory testing, and it does the buprenorphine metabolite testing, which I think is critical in this day and age at this point. So, there's a screening test, which is an immunoassay. It just shows antibodies. What we see is there's tons of false positives and false negatives. It's cheap, right? It's quick, but we generally don't really use them in our clinical setting at this point. I would never make a treatment decision based on a rapid screening urine testing anyways. And so being judicious about what we're doing and sending out, and it can cause alarm for patients if they see something show up and it's really a false positive and they say, I didn't do that. And so the only time I generally use it anymore, there's very, 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 very limited, it can show bup, but it doesn't show metabolites. So if someone is dipping their urine, right, which means they are dipping a Suboxone strip in the cup, that's all it's going to show. But it's not going to show the metabolites. So it doesn't really give information in this day and age. I don't think. I think Dr. Rimlin and our agency, we all kind of feel the same way. So we send out for confirmatory. So it's mass spectrometry and chromatography, and it is shows a lot of things. And then if things come up positive, it does confirmatory testing. So sometimes amphetamine will come up, right? But it's someone who's prescribed a stimulant, or it can show if it's actually methamphetamine, and it shows amounts. It shows cocaine and metabolites, fentanyl and metabolites. It shows a lot of really good information. And then it shows the buprenorphine and their metabolites, the norbup metabolites, which is so important for us. And it also shows the amount. So very, 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 very low amounts are very different than someone might just be taking one strip maybe versus like a steady amount. So it's really, really good information. And I think I would recommend investing in this type of approach if you're going to do this regularly, because it really helps you make good decisions and work with your patient on their goals, right? So Ohio. So considerations for prescribing in Ohio. I have a kinship with Dr. Rimlin and Dr. Margolius because we all practiced medicine in other places before coming back home some years ago, and California and New York, and we're like, whoa, these regulations are silly, but very real. And so Ohio has historically been one of the most restrictive states, and which has been really interesting for being one of the states with the highest overdose deaths. And so it really has felt like it was hindering itself from progress for a long time, in my opinion. But there's definitely been some recent updates to the law, which have been really great. I know there were some really great docs who are working hard on advocating at the state level for some of the complex changes and laws, which I'm not going to necessarily go into. But this was from Dr. Rimlin and I were at ASAM last year, and we saw this information. There's only 10 states in the country that had regulations on prescriptions of Suboxone. We were one of 10, and if you look at the purple boxes, we were one of only 4 states that had the most restrictive regulations. We had dosing limits, we had counseling requirements, and we had frequency of visit requirements. And so this really was eye-opening to me when I saw it, because if you can see 40 other states, the government doesn't get involved in how to prescribe a medicine, but we were one of them. Thank goodness some of that has changed, so that we can just better take care of our patients. So there was just a recent revision of the law, so that counseling requirement has been removed. And I know, lots of patients benefit from counseling, right? And benefit from that, all of those other ancillary services. And we in our clinic offer all of that, but we just don't require that, which I think has been really, really helpful. As Dr. Rimlin alluded to, the dose limit remains, but it was changed to 32 milligrams if you have the consultation of a specialist, or if you are an addiction medicine physician or an addiction psychiatrist. Again, we don't do 24 is pretty common. I think there are some patients that we would like to be able to do 32 on, and so this is really helpful. And then previously, there was a limit on how frequent you could do prescription. So during the induction phase, you had to see people weekly and do that prescription weekly. And then for the next 3 months, it was every 2 weeks. And then after 3 months, it was monthly. And so we have been following that guideline in our clinic, but this was changed just to, you could do 1 month for the first year. So you don't have to do those every 2 weeks once you feel like the patient is stabilized. And I will say, lots of patients like coming in more frequently, right? You say, you're ready to go to every month now. And they say, I feel it better for me for accountability or for just checking in. I want to come in every 2 weeks. Is that okay? Totally fine. But it's nice to have that flexibility for folks who want to come in monthly. And so to answer that question, I think that the monthly was related to the dosing. And so I do think, we still need to see people monthly for the first year. And then after that, we can space it out. We have folks that come in every 2 or 2 to 3 months after that first year.
Okay, awesome. We are almost done, and then we'll have time for discussions and questions. But we wanted to end with talking about practicing from a harm reduction lens and sort of what that has meant in practice to us as we prescribe buprenorphine. And I think for me it boils down to a couple of things. One is really that we embrace folks with all treatment goals, right? So we certainly have some people who come in and their goal is abstinence from every drug, right? Which we support and embrace. We have a lot of folks who come in and their goal is to stop using fentanyl, but their goal at this moment is not to stop using methamphetamine or cocaine, and we embrace that. And then we have other folks whose goal right now is to reduce their use, right? Reduce their dependence, reduce their chance of overdose, but might still be using intermittent fentanyl, and we embrace that as well. So I think we really try to recognize that this is a life-saving medication, for all comers, right? Life-saving medication, period. And so, welcoming folks and really partnering with them on what their goal is, right? Which might be different today than it is in a week or in a year. And then I think we are really blessed here to have a lot of the support resources internal at our FQHC. So we have, a really robust psychiatry department. We actually have more psychiatrists than primary care docs, which is like the case nowhere, and is amazing for me. We have primary care. We have an SUD program that does IOP and PHP and counseling. And so we're able to offer those to folks, but we don't require them to do anything. It's really been important for us to have no pre-treatment requirements to make this truly low barrier and allow people to get on this medication even if that's the only thing they want to do at this time. I don't think that having these other services is necessary at all to prescribe bup. I think, knowing where you can refer patients or get them connected to other things when they're ready is important. And then this is just a quote I liked. The Gun Center did like a really beautiful piece a couple years ago where they interviewed a lot of folks in Cuyahoga County who had experienced an overdose themselves. So they interviewed those individuals as well as their family members. And it's really, really worth a read. But I really loved this quote of how this person framed harm reduction as really just holding this unconditional positive regard and being a place that just always has open doors for folks sort of regardless of where they're at. And then, yeah, not a lot of takeaways, but I think, my hope is that, folks can recognize that prescribing buprenorphine in your clinic can be really rewarding, really, really impactful, and that it's really not that hard, and is something that you can do. And for me as I'm an internal medicine trained primary care doc. So I do a lot of just general primary care and see folks for all kinds of things. And this is far and away my favorite thing I do. It is just so rewarding. And I think to get to walk alongside people in this journey is just such a privilege. This is just a text from one of our patients we've been working with for a while. So thank you all so much for listening, and we'd love to engage in any questions or discussion.
Great. That was very informative. I'd like to open it up, and feel free to just unmute yourself if you'd like to ask a question. We currently do not have any questions in the chat. So please feel free to unmute and ask your question if you have one. Any comments, reactions? It's a quiet bunch today.
Can you hear me?
Oh, yes, we can hear you. Thank you.
Okay. Oh, good. It is Sybil Marsh, and I am the program director of the family medicine program at UHCMC. And I have been prescribing buprenorphine naloxone for opioid use disorder since about 2004. So, we've gone through many phases of the opioids available in the community and the attitudes towards treatment. My question is, it really seems like from about 2012 onwards, we have been training several generations of residents who, on the one hand, have a better understanding of substance use disorder, and willingness to treat it and to consider it as a chronic illness and so on, but that those same generations of residents also have severe opiophobia from having gone through the time when physicians were taken off in handcuffs and hospital administration, the legal department sent a team of people around to physicians prescribing opioids, telling them that they could lose their license and that they needed to sign a contract with the hospital about how they were going to prescribe and so on. Residents witnessed that period in our history, and I think it has spilled over into them being unwilling to prescribe buprenorphine naloxone. That they say, yeah, we get it. It's a chronic illness. This is a very good medication. It's very fulfilling to prescribe to these patients and blah, blah. We're not touching it. And I wonder, for you guys being more in those generations, what's either a kind of policy level way to remedy that, or, how do you advise recruiting more prescribers? I would say that if you took this presentation and maybe divided it up into 20-minute chunks, that it could maybe get onto our GME portals and become something that residents could watch and learn from. The hours like a bit long for them, but that might be, this presentation alone might help to influence some of those residents. But, I'm interested in your take on that.
Thanks so much, Dr. Marsh. Yeah, it's a really interesting point, and I mean, you've sounds like you've gotten to see a lot of the generational changes in all components of this. It's interesting. I grew up in Ohio, as I think all three of us, Dave, Ellie, and I all did. And I trained on the East Coast and the West Coast. So I did my residency training at UCSF not that long ago, right? Like not that long ago. And prescribing buprenorphine was so normalized there. Every graduating resident in my class, regardless of what specialty they went into, was comfortable starting bup and methadone in the hospital, right? And we didn't even, I mean, without consulting addiction medicine, like it was really normalized in what we saw. And so it was, I wanted to come home and practice in the state and community where I grew up, but it was definitely a bit of a shock for me coming back here and seeing just how attitudes were different and how, and I think, it's related to many things, but as we saw, like even the laws themselves, right, have been so restrictive here historically. But I think like any opportunity to expose medical students, residents to this, in the form of lectures, but I think just also in the form of like daily practice, right? And getting the opportunity to spend time in addiction clinics that are doing this work every day and, sort of seeing that, this is fun and rewarding and, and something that I could do. I think in general in this country, we still don't do a great job of teaching about addiction medicine to medical students and residents. So I think from a like really practical standpoint, I know, we're at the centers and in FQHC, we certainly welcome any opportunity to involve trainees in this work and just coming and seeing, we're doing this in our walk-in clinic, but we're also doing it just embedded in primary care and psychiatry. And so we have some students from CASE coming for the summer. They're after their first year. We have some addiction medicine fellows, but I think, really offering this as like part of the curriculum and then offering opportunities for people to just see this, I think is so, so important because if you don't see something, it's hard to be interested in it and it's hard to be comfortable with it.
Yeah, thanks, Jody. I would just kind of echo Dr. Marsh. It's a good point. And, I did my training in San Diego embedded in like a homeless FQHC was kind of my continuity clinic. And back then, probably 2017, the medical director and I had the waivers and we were seeing people using and we said, let's just try. And it was where I was teaching my attendings how to prescribe Suboxone because they were scared too, and it was just that incremental little bit. But I don't think that I have experienced that trauma of seeing what the folks that you are describing have because I think you've heard about it, but we never that wasn't in our training environment there. And here I think so. I have I think one of my fellows is from UH is on here today, but I think it's been slow even for us, to get learners to come and want, to learn. And I have a fourth year psychiatry resident who's been with me all year. And from the beginning of the year to now, she's so comfortable with the gray and with all of the, she had said, boy, when I started, I needed a plan for my day and I would chart review and I needed to know how it was going to go. And I was so uncomfortable with the unknowns of what could happen in a walk-in clinic. And she just like does it with me and she's gotten a lot more comfortable. But I think that's the best way is really seeing it. And we have a really great document that I think would be happy to share that Dr. Rimlin worked really hard on with me, but it was mostly her. Looking at all of the Ohio laws, and then we went through all of the ASAM guidelines for best practices, and then we kind of said, and this is what we're doing, so it's really clear that we're following the law, and our kind of the rationale. And so I think we just feel comfortable that we're operating within the law because we spent a lot of time with it. We reviewed our protocol with our legal team. We wanted to make sure if we're going to do something that's a little bit different in the Cleveland community that we had ironclad kind of legal backing. And so I think we feel really good about that. And so I don't know if that helps your question, but we always want to, I think so many learners and young docs just need to see it be done and get that reassurance, you know?
I think that would really help if you have a good document like that, is just to kind of make it available, that if in all of our systems we use the same kind of criteria, I think it would give people a lot of confidence. Where I am, the treatment agreement, you know, that's the controlled substance agreement, is based on the old law, and it has not yet been updated. And all of the templates for our notes are based on where's the counseling and is it one of these types of counseling and so on. You know, that reflects the older law that really scared so many people away. But if we had a kind of prototype so that we weren't each making our own document, and, you know, we might adapt a little bit, that would be really helpful for me anyway. So thank you for volunteering to share that. I would love to see it.
Sure. And I do think, Dr. Rimland, we probably have to update from the latest change in the law to, but yeah, I think that we'd be happy to to share that.
I'm almost done with it, actually.
Yeah.
So it is, there were a lot of updates to include as the law changed last fall.
Yeah.
And we did, I mean, yeah, Dr. Marsh, we also did spend a lot of time a couple of years ago when Ellie and I really got interested in, really got involved in this work on revamping our contract, you know, treatment guidelines to fit the law, but also fit our culture and be harm reduction focused and all of that. So I am more than happy to share any of the resources we've come up with. And I think having a community of folks from different institutions, you know, talking together on how to best do this makes a lot of sense.
Dr. Rimland, would that be available in May, do you think? Because we have our next webinar scheduled for May, and I was thinking we could just provide an update then with that document, just so folks could, you know, re-engage on it and keep the conversation from today going.
Yeah, I think we can do that.
And that would just be like
a good deadline for me to get everybody from our team to review it and agree to it.
And I was thinking just like a 10 to 15 minute update on it and then making it available. Yeah. That's a lot of work, so I want to be sure that we recognize you for your work as well. Great. Any other questions? I just put the survey link. We really would appreciate your comments and feedback on the survey. I know we're all survey fatigued, but we really need these to go to CDC to continue their support in our community. We're just one of 13 other subgrantees through Cuyahoga County, and so it's really important. So we're not just asking for your feedback just to evaluate ourselves, but we really like to share your perspectives with CDC. And then just a news update of something that happened this week. So HHS is continuing the public health emergency on the opioid crisis. So we were glad to see that. Our consortium newsletter goes out once a month. It's now coming out mid-month. So if you're not already getting the consortium newsletter, it's full of training, policy updates, state and local updates. So please sign up for that newsletter. And like I said, it comes out usually between the 10th and 15th of the month. And all of our previous issues, if you'd like to take a look at those previous issues, we do have those online so you can easily access them. I know things get boggled down in email as well. And then just again, the survey is very important. There's the QR code if that's easier than the link that's in the chat. As far as the Opioid Consortium, we had focus groups in the fall looking at individuals who use opioids for chronic pain management, just trying to get their perspective, how we can serve individuals, listen to people with lived experience and find out what works for them. And so we will be releasing a report on the findings of those focus groups. So that'll be coming out end of April, early May. And then we plan on, again, our next education series will be May 8th. We are toying around with a couple of different options for speakers, so stay tuned. But for July 17th, we're going to host an in-person forum, and it's going to look at both acute pain management and chronic pain management, and the use of opioids and the use of non-opioid treatments. And so we're just putting that teaser out. If you could save the date for July 17th, it'll be in person at the Center for Health Affairs, likely to be a morning event, so that you can just come straight there and then go, you'll be out before lunch. So those were our consortium updates. And I know in the past, our education, there's been a request for more information on stigma reduction. So I'm just sharing a couple of things related to stigma reduction. There is the pledge to end stigma from Recovery Ohio. It's individuals and organizations, but I think it's more geared towards individuals signing on at this point. So that QR code will take you to that pledge. We've really encourage you to use person-first language when we're talking about substance use disorder and addiction. And so words matter, and we've included this RAC card that is available as a quick reference point on people-first language. And then the other is the Beat the Stigma campaign. There's a great tool on the website in Ohio, the Beat the Stigma, and it's a game. And it's really good. I encourage you to use it for your staff, for your departments, staff meetings, just to keep it front and center of how we are thinking about addiction and mental health and substance use disorder. So just reminding folks about that tool, that fun opportunity, because it's a game, to really use that as an educational tool. And I'll open it up again for any questions from those who are still with us today. Any questions on the line?
I don't have a question, but I actually want to give a comment. Well, thank you guys for all being here. I just kind of thinking, we kind of alluded to our walk-in clinic, but I do want to make sure that that resource is shared here for everyone on the call, that the center does operate a walk-in clinic in Gordon Square called WinMat, Monday through Friday, usually 8:30 to 4 is we want people to come in, but you can walk in and get seen by a provider and kind of get the start of those services. And we're opening a second location on the east side at our the Uptown location. It's on Euclid Avenue near University Circle in April. So just if you're not sure what else to do with a patient, please share that information. You can send them to us. We'll be glad to see them if the need arises. So and reach out with any questions to Dodie and I if you have any more questions about that.
Well, that's a great point. One of our deliverables for our current grant with the Opioid Consortium is the linkages to care. And so really looking at the health systems and how they're linking to programs in the community that are available. So I guess one question I'd have is, what is the current collaboration, say, between the centers or FQHCs and emergency departments, who emergency departments may be like the first line and they need to seek care from a maintenance perspective? What is your relationships there?
Dodie, do you want to take that one? Or we're working on building that more. So, I think go ahead, Dodie. I don't want to, yeah.
Yeah, well, we started our walk-in clinic like exactly 1 year ago, so it's relatively young, and we started that. I mean, mostly based on us seeing a community need and seeing that as a really essential piece of the continuum of care. And so we've been working on building relationships with other community organizations, and really making sure that folks know this is a resource and option in our community. So, we've done that with the county jail, for example. We've met with their team multiple times, and they're often sending folks to us upon release from jail. We've had some, contact with the emergency rooms, but that's like definitely an area we've identified of needing to strengthen and build our relationships. There's, I think, our hospital systems, we have many of them and all these different departments and a lot of complexity. And I think there's certain departments at certain hospital systems that know about us and that we have relationships with, and other areas where, we still have work to do in building those. So I think, please share that this is open to anyone, right? And we will have an East and West Side location come April 7th, which is coming right up. So we definitely, want everybody to know about this as a resource for anyone in our community.
And Kelly just asked a question: is the walk-in clinic only for MAT or primary and psych services as well?
So it's a really great question. The WinMat clinic is our walk-in MAT clinic. So that is really for folks with opioid use disorder wanting to talk about treatment for opioid use disorder. We also at both of those locations have a BHUC, which is a behavioral health urgent care, which is a walk-in clinic for folks with psychiatric needs. So that's, at the same locations, and people are triaged and kind of triaged to one of those providers based on their needs. We do primary care at all of our sites, but we don't, as of right now, we don't have like just a walk-in primary care clinic.
And Robert, I see you have your hand raised. Go ahead.
Hey, Jody, thanks for coordinating. I think I missed 90% of the presentation, unfortunately, because of the 72 meetings I have today, but I was able to kind of come in towards the tail end here. But I'm over at Metro Health, and I know that obviously we do the healthcare in the jail, so I don't know if that work you were partnering there was with some of our providers or not. But I'd be happy to connect and see if there's anything I can do to make some connections to some of our folks internally. So Jody has my contact info, but I'm happy to connect and have more conversations and figure out how we can be a helpful partner there.
Awesome.
Yeah. Awesome. Thanks. So yeah, thank you so much, Robert. We met with some members of the jail team. I mean, we had talked with Dr. DeRocco, but also like Megan Riley, I think has been our primary contact for a while. And I think we've had a good relationship with them that goes both ways, right? We're able to reach out to their team when one of our patients ends up in jail and make sure that they have the right information about their treatment. And then they've also, I think, told folks about our walk-in clinic as an option for getting treatment once they're out of jail.
Great. And I'm also, it might just be nice that I might want to just pick your guys' brain anyway. I'm on the government affairs team, but as far as buprenorphine and what we're looking at the state level, it might just be nice to pick your brain anyway. So
absolutely,
happy to connect.
Yeah, absolutely. And I think another thing we will certainly offer is like anybody who wants to come visit our clinic and just see it and meet our team. We love when folks do that just to learn more themselves or to get a sense for where you might be referring your patients to. So we definitely welcome that.
I'm trying out the new tools on here. So I hope you see I circled.
Jody, it feels like you're passive aggressively circling the email, so I reach out to them.
Yeah. Dr. Marsh, did you have another question?
This is probably more offline, but since University Hospitals is closing our family medicine residency program at the end of in June 2020, we'll have a certain quite stable and possibly some new patients that we need to rehouse. So we probably should coordinate too for those, East Side type patients that might be able to see you. I did have a comment, and that is I do find the sort of quality of care is different if you can have a continuity relationship with patients, as opposed to just, kind of have them come in and come out. And if the full primary care, including gynecologic care, can be integrated with the MAT, it's not always possible to do that, but it does seem like we ought to be working towards having sort of multi-skill clinics that are going to be able to provide that spectrum of services in conjunction with mental health services when they need to. I am just anecdotal from my experience, and I'm sure there's like data. The piece that often gets missed is for women getting MAT, their gynecologic preventive cancer screening and that kind of care. So I just wanted to put a plug in for, problem solving for how people can get access to the full spectrum of primary care, preferably with continuity with someone that they know and trust.
Yep. Yeah, that's an excellent point. And I guess what I should say is in our clinic, it's walk-in MAT and there's walk-in psychiatric care, but we have it all in the same space. So unfortunately, we're not all trained in psychiatry, MAT, family medicine, or internal medicine, but we have it all in-house. So we try to limit, Dr. Rimland may be able to treat all of their medical care, do their MAT, and then do the warm handoff to psychiatry in the same building, or vice versa. So we try to make it so, and folks don't have to go anywhere else. And what's really, really nice, I think one of our clinical pharmacists was on here, is we do have a clinical pharmacy at our sites, which means that they can assist us too with hepatitis C treatment and some of the other things that are really prevalent in this population. So we kind of wrap around folks and hope they don't have to see too many people.
Yeah, that's excellent. And, everyone doesn't have to be able to do everything, but I think if we have that trend of moving towards more integration rather than more, splintering off, like I only do this and good luck with finding an appointment with, these 3 other people, it's going to be so helpful for the clients going forward.
Absolutely. Navigating the system, it's difficult for people who understand the healthcare system, but then you let alone the patients that have that could potentially have these challenges to understand what their next steps. Those warm handoffs are so important from a navigation perspective. Mm-hmm. Appreciate that comment. Any other questions? We still have some folks on the line. Please unmute. I'm not seeing any additional questions in the chat. I really appreciate everyone's participation today. The Opioid Consortium, as I mentioned, will get together again in a webinar on May 8th. And then look forward to also the July 17th in-person forum. And we're happy to make connections. So if there are thoughts after this session, please feel free to use me. I can make the connections or connect you to the right people who need to respond for the resources. We did have a request for the slides, so as long as Dr. Rimland and Dr. Yonchar are okay with us PDFing and sending those slides out. Yes, okay. So we'll send those to all who have registered for today, and then the recording, it usually takes us about a week to turn around the recording of this, and we'll send that out, and it'll also be linked in the next consortium newsletter. Great. Well, thank you all, and I'll give you 4 minutes back for your day, and totally appreciate our presenters today. Thank you, Dr. Rimland, Dr. Yonchar, Dr. Magolias. Can't thank you enough, because this was exactly the information that we need to be sharing. And we are so thankful for your time and your commitment. We look forward to having this spread a little bit through our recordings and see what other connections we can make through this.